Hi everyone, this is Dr. Hartman, and this is the presentation on disasters. Very sorry that you all are missing your disaster day. It's a lot of fun, but we will give you the concepts that you need so you'll be ready for your test and understand at least what goes on during disaster preparedness, etc. So triage is one of those words we hear and think about as far as assessing patients and deciding who goes where. Triage in disaster situations is a little counterintuitive because if you're like me, you feel like you want to save the people who are worst off quickest and be with them. But actually, in a disaster situation, you want to do the most good for the greatest number of people. So triaging out in the field in disasters is a lot different than it is in the hospital. So here's an example of triage. So regular triage, the cardiac arrest person would be first, which makes sense. They're worst off. Then the incomplete amputation, then the stable abdominal wound, and then the arm fracture. And then in a disaster triage, the incomplete amputation would be first, followed by the stable abdominal wound, the arm fracture, and then someone who's cardiac arresting. And I'll show you how they come to these determinations here. So there's a thing called Start Triage. It's something that it's like a program and people can be certified in triage. There's different levels for the basic level or for like nurses. We would need to triage someone within 60 seconds per victim. That's the max time you get. First responders, theirs is a little more stringent and they get 15 to 20 seconds max to triage people. So mainly what we want to do is take that 60 seconds to assess and move on. And one of the things that they do to help you remember Start Triage is ventilation, perfusion, mental status, or 32 can do. And what that stands for is 30 ventilation. So if someone is greater than 30, they're going to fall in the red category, and I'll go through that with you. If their capillary refill, their perfusion is greater than 2, they're going to be in a higher risk. And can do means the mental status. If they can follow commands, then that's a good thing. So if they're under 30, under 2, and can do, they're going to be triaged first towards the beginning. So they in mass casualties, they have these cloths that they cover the patients with, and that's for quick identification, and so that when they go through after they've made the initial triage, they know who goes where. So red is emergent. It's life-threatening injuries with a high possibility of survival once they're stabilized. So we're probably going to go and treat those red people first. The yellows are still major injuries, but they're not life-threatening, and then they can wait 30 to 60 minutes. And then the green are the non-urgent or the minor injuries that are not life-threatening. So they're usually your walking wounded. And then the black, it's under expectant. It means basically they're expected not to live, and just comfort measures. So this is an algorithm that represents Start Triage. So if you look at the top, so you're standing there, you walked onto the site, and you stand and you call out first, say, anybody who can hear me and can move and come up to me, please do. So those are the walking wounded come, and they're going to be classified as minor, and then you're going to put them in a little, their own area, so and just have them sit tight. They'll eventually have to be fully triaged when you do the primary triage, but not right now. Right now we're just trying to determine who goes where for acuity level. So then the non-walking ones, you're going to go and assess all these respirations. If they have respirations, or say they have no respirations, you're going to reposition their head and look, listen, and feel. If they still have no respirations, you're going to again reposition again, and if they have none, then they're considered dead, and you move on. The other, if they do have respirations and they're under 30 minutes, or yeah, 30 per minute, you're going to go on to the perfusion part. And you're going to take a radial pulse and you're going to do the Blanch checks. If they have a radial pulse, if the radial pulse is absent, they're considered a red, an immediate one. If they have a Blanch test and it's under 2 seconds, you're going to check the mental status then. If they follow commands, they're yellow, they're delayed. If they can't, then again they're red. So pretty much just look at that and you go through and you're going to, again, you're going to check respirations, perfusion, and mental status. Those are the 3 things for the START triage. Okay, so you come across the bus train accident using the START triage. How would you triage the following people? So the first one has agonal respirations remain after 2 airway opening attempts. So I'm going to give you a couple seconds to think about it. Okay, if you said black, that would be correct. Remember, agonal respirations are not good. You've tried to reattempt to open the airway twice and nothing happened. So this person is going to consider be black and comfort measures only. The next person has a respiration of 26 per minute. He has a capillary refill of 2 seconds and he's confused. Okay, so we've got our respirations. We're under that 30 mark. Okay, we are at 2 seconds, so that's good, but they are a little confused, so I'm going to give you a couple minutes to think about that. Okay, so this person would be classified as red. Say if they were alert and oriented, then they would probably be a yellow, but since they're confused, they're going to be a red. C, we're at 34 respirations per minute. What would you classify that person as? Okay, if you said red, you would be correct because their respirations are greater than 30. Moving down to D, we have a respirations of 26, capillary refill of 2 seconds. It points to the abdomen as the site of pain. So you're asking him a question, where's your pain? And he points to the abdomen as the site of pain. So, what do you think? Okay, so if you said yellow, you would be correct. Respirations are under 30. Capillary refill is 2 seconds, which is what we want. He can follow commands. He knows where his pain is, so he would be a yellow, he or she. E, walks to the elm tree when instructed to. Okay, if you said green, you would be correct. And that was an easy one because not only do they follow commands, but they can walk to the tree, so we're good there. F, respirations 26, capillary refill 6 seconds. Okay, you should have said red because his capillary refill is 6 seconds, so he's not perfusing as well as he should be. Okay, so after you've completed the START triage, flip here, then everybody has to go through the primary survey, and that's everybody, the green people as well. Okay, so that's when this includes assessment and life-saving interventions. And this, we're going to follow the ABCDE rule. And this is one of the things I feel badly you missed out because you practiced primary survey on the disaster day. But anyway, so we always start with our A, as you know that. Airway, do they need intubated? B, breathing. Do they need oxygen? What are their breath sounds like? Do they need a chest tube? C, circulation. You're going to get the IV started and IV fluids. A tourniquet if they're bleeding. There's a thing called Stop the Bleed, and every AED now that's out in the field should contain a tourniquet. And there's a program you can go through at some time. I would recommend it, and it's how to apply these tourniquets to stop the bleed. A lot of times when they have, especially these mass shootings, if the bystanders can get the bleeding stopped, you can save more lives that way. D, disability. You want to immobilize the spine, do a Glasgow Coma Scale check. And then E, expose. You want to remove all the clothes, do a thorough skin assessment, but do keep people warm, prevent hypothermia. And people can move from one color to the next, so they may start out as a yellow and then all of a sudden turn into a red. So those assessments need to happen quickly and to keep up on them. So this is what, if there's a mass casualty or for any reason, kind of how they set up a command center at the site. The incident command center commander has the ultimate responsibility, and followed by the safety officer. And the safety officer can override the incident commander if he feels like the situation is not safe. Say there's an earthquake and they're working on some building and then he realizes that it's getting ready to collapse. So that person can override the incident commander. The logistics person is in charge of the money and the supplies. They set up all the food services for all the volunteers that come. They help the first responders. If the first responder get hurt, they provide medical services to them. And again, like I said, food, supplies, everything. Operations are the workers at the scene. And finance, obviously, pay for stuff. Pay for the money for the bills and stuff. Okay. So I already mentioned a little bit about this, but again, here's just the slide writing that out. Logistics, order and obtain personnel and equipment, set up and maintain incident facilities, provide medical services and food to the incident people. Finance, pays the bills, do the cost analysis, compensation for injury damage before and after the disaster. Nuclear radiation. So there's exposure, and we are going to do a little exercise on when we meet during the class time on Zoom. So make sure you got your colored pencils and your drawing in hand, because we're going to get time to work with it, and then we're going to share screen so you can show other people. So anyway, external radiation passes through the body. So we can do this contamination triage outside the hospital. They double bag everything. It's either in a yellow or magenta bag. Afterwards, what happens is they remove the clothing, wash first with water, and then you go to the next station and wash with soap and water. You have to use a I never say this word right, dosimetry, dosimetry. Basically, there's those little badges that you see the x-ray techs wear to make sure that they haven't had too much exposure to radiation. After people have been exposed, they can get acute radiation syndrome, which it's kind of like when our cancer patients have radiation treatment, and those beams, what it does is it attacks the rapidly producing cells in the body. So those are usually the cells that are producing our blood products. So attacks the white cells, the platelets, and the RBC. So anybody who's been exposed to nuclear radiation, we're going to draw blood levels to make sure they're not having incidents of that. So draw a baseline, they probably get sent home, and then they come back and they monitor it again to compare. Most people are symptom free or have mild signs and symptoms such as nausea and vomiting that will resolve. So like I said, they'll draw the CBC, release the person, and then they come up back for follow-up lab work. So yeah, that's kind of nuclear radiation in a nutshell here. So then there's different levels of PPE. I guess this really hits home now because I think a lot of these people are in level A, and these are kind of cartoon-like drawings, but basically I want you to know that it goes from highest to lowest level. And the highest, level A, you are protected respiratory, skin, eye, mucous membranes. They have a scuba suit, so basically their air pack is within the suit itself. Everything's self-contained. They have it's gloves, boots, the whole shebang. So level A is the highest. And then you go down to the level B. Highest level for respiratory, less for skin and eye. The suit, it still has its air-contained suit, but it's not vapor tight. And then level C has an air purifying respirator and chemical resistant gear. And then level D is your standard PPE, which is a person that's kind of off to the side there. So just know it goes from A to D, with A being the most protective. Internal disasters are the events that result in loss of resources used for regular activities. So if there's an internal disaster within the hospital, let's say a water main breaks or something, so they have no water. The main thing is you call the administrator and call, and they can initiate the emergency operations plan. So every hospital is required by JCAHO to have their emergency operations plan so that they can snap into action. Not sure we had that ready for the COVID because hospitals are scrambling to find more masks and to convert their rooms into negative pressure rooms and so forth. So I'm sure we'll hear a lot of that about that in the future. So the general guidelines is that they'll call the emergency person on call. They're going to use walkie-talkies or personal phones in case there's a phone failure. Usually there's a red phone on every floor. I don't know if that still occurs, but we always joked that was a bat phone and no one could touch that or use that. That was emergencies only. Because if the other lines get cut or something, it was wired differently. There's a command center that provides security and guidance throughout the emergency. The goal is to maintain normal operations as much as possible. And I think even in the advent of the COVID virus and how many changes are going on, hospitals are still trying to maintain some kind of semblance of normalcy. So yeah, if evacuation is needed, they do horizontal first. So you're going to go for floor horizontally and then move vertically. Do not respond to media requests. There's usually one person who's going to be one or two people who are the representatives of the hospital. So don't you go answering any questions if someone asks. Just direct them where they need to go. And hospitals should be practicing these drills twice a year. So that would be interesting to follow up on that. See if that's going on. The nurse's role in this kind of emergency, go to your regular unit, wherever you're assigned. Make sure you're assessing all your patients. Do a head count, a census report, and in case the computers go down, you can write all that out so you can have that. Do whatever you need to do first for safety. Moving on to natural disasters, tornadoes, floods, earthquake, blizzards, hail, that kind of stuff. So first, and then there's internal disasters, which I kind of alluded to a minute ago. Fire, broken water mains, explosions, hostage taking, infant abduction, all that stuff, acts of terrorism. So you suffered a internal disaster and you need to quickly assess the situation. So you take stock in what you have, what you need, and what you lost. Sounds like a song. And then a more detailed assessment. Physical equipment and supplies. What is the current condition and the safety risk? Do you need to get people out of there? Do you need to get more people in here? If it's internal disaster associated with an external disaster, do patients need to be moved or discharged to make room for external victims? So say there's a tornado and half the building fell down or one of the floors was damaged and you have to move all these people to another spot, either within the hospital or maybe to an extended care facility. There's all those things to consider. If it's an external disaster and you're going to see an increase in census, will you be ready? What kind of supplies do you need? What kind of transportation to get people there, to get people out? This was one of the things where back when 9/11 happened, all the hospitals in central New York were getting ready for this big influx of patients. And then unfortunately, because so many died, they hardly had any. Again, this is a review of that other graphic we showed. So you have someone in charge, a safety officer, logistics, operation, and finance. Much the same in a hospital as it would be for like going to a site. Okay, so hospital beds are urgency needed during a meningitis outbreak. Which patient is appropriate for discharge? So you have a 58-year-old male admitted this morning with an angina. He has a history of a cabbage 1 year ago. We have yes or no. Can he go? What do you think? My guess would be no, because he could be having like a potential heart attack or something if he's got angina. And he also has history. Okay, B, 50-year-old male with a history of diabetes, rotator cuff surgery scheduled this morning. Can he go for a bit? I would say yes. That's a pretty much an elective surgery. Not that he doesn't want to have it, but it can wait. So I would discharge him and reschedule. A 7-year-old male admitted yesterday with PNA and dehydration. What do you think? I don't know. This guy would want to save, mainly not save, but keep, mainly because of his age and his dehydration. He seems a little fragile to me, so I guess I would keep him. 65-year-old female, fail with a fractured hip and is scheduled for a hip replacement tomorrow. What do you think of that one? I don't know. I think she needs to stay. She needs to be immobilized. She's 65. The hip replacement probably can wait. This is one that's kind of difficult for me because I would be worried about if she's going to have a pulmonary embolus because of the hip fracture. Um, yep, I would keep her. Okay, so that's this piece in a nutshell. And I hope you learned something. We'll talk soon.